Good afternoon, everyone. This is Lindsey Tatum, nurse practitioner, and this is my Doctorate of Nursing Practice project for Maryville University 2023. The title is Opioid Use Disorder. My committee members were Dr. Carol Berger, Dr. Maria Snell, Dr. Mark Pauls, and Dr. Fady Haneen. Introduction. We're going to discuss the prevalence, the issue, and the goals. On average, 130 people die daily in the United States due to fatal opioid overdose. Unsurprisingly, opioid use disorder, or OUD, has become more prevalent. Just a few years ago, more than 10 million people in the U.S. reported misusing prescription opioids, with 80% being over 26. The issue is one of the significant challenges with opioid use disorder treatment is managing withdrawal symptoms. When withdrawal symptoms are not controlled effectively and monitored closely, it can lead to significant relapse, sometimes with fatal consequences. To effectively manage symptoms, early identification and assessment are essential. The detoxification process involves the administration of medication in a controlled and medically supervised environment to reduce the severity of withdrawal symptoms that occur when people stop using opioids. The goals was to provide a detoxification that is based on the COWS assessment, or Clinical Opioid Use Withdrawal Scale, as opposed to a standard scheduled detoxification for all patients, in hopes this could allow for fewer withdrawal symptoms and a faster detoxification process, potentially leading to improved healthcare outcomes. Purpose. The Scholars Project aims to individualize detoxification protocols for patients admitted to a substance abuse facility diagnosed with opioid use disorder. The study aims to reduce severe withdrawal symptoms and shorten the detoxification period for opioid use disorder patients. In our organization, patients were getting the same scheduled detoxification regardless of any other variables. The purpose of the Scully Project was to reduce severe withdrawal symptoms and shorten that for those patients. Secondary aims include increasing nursing education in administering the COWS assessment, improved patient satisfaction, fewer medical concerns and interventions during detoxification, and implementing a more objective assessment for nurses and providers. Literature review. A variety of databases were used to research and develop the Doctoral of Nursing Practice scholarly project. An integrated literature review was conducted using Cochrane, Cumulative Index of Nursing and Allied Health Literature, EBSCOhost, and PubMed. The search included the English language, full-text, peer-reviewed articles published within the years of 2017 through 2022. The articles were grouped into the following 4 themes: opioid use disorder, withdrawal symptoms, COWS, and buprenorphine. These themes provided the most support and guidance for the scholarly project. The objective of the review was to substantiate the benefit of utilizing the COWS assessment in the inpatient setting to manage clients in opiate withdrawal and treat them using buprenorphine. Opiate use disorder. Approximately 3 million individuals in the United States are diagnosed with opioid use disorder, and over 10 million people misuse opioids in a year. A reported 64 to 78% of people relapse within 1 month of completing an inpatient opioid withdrawal management, and few have prolonged abstinence, contributing to a revolving door for reoccurrence patients that get admitted. On average, patients stay for 5.7 days in an inpatient treatment facility. This disease mimics the patterns of other chronic illnesses. Signs and symptoms can be severe, and long-term adherence to treatment is often waxing and waning. Research and evidence-based practice show that using the clinical opioid withdrawal scale to treat opiate withdrawal symptoms is the most effective option for early withdrawal detection and appropriate symptom management clinically and objectively. Withdrawal symptoms. While withdrawal is not normally life-threatening for opiates in a medically stable patient, it can be extremely uncomfortable. Common symptoms of opiate withdrawal include autonomic instability, musculoskeletal pain, muscle spasms, nausea, diarrhea, insomnia, anxiety, irritability, flushing, runny nose, eyes tearing, elevated pulse, yawning, and excessive sweating. This can result in dehydration, which can be life-threatening. The onset of withdrawal symptoms of the opiate used depends on the opiate used and the half-life of the specific substance. COWS. The Clinical Opiate Withdrawal Scale, also known as COWS, is a provider or nurse-administered score-based assessment comprising 11 common opiate withdrawal signs or symptoms. The total sum of the 11 items can be used to assess a patient's level of opiate withdrawal and to make inferences about their level of physical dependence on opioids. The COWS is a useful tool, outperforming most opiate withdrawal instruments in evaluating treatment results. Buprenorphine. Buprenorphine, approved in the United States as an office-based treatment in 2002, is the preferred treatment among people using opioids. Buprenorphine helps decrease cravings and blunt the euphoric effects of self-administered illicit opioids. Buprenorphine has shown efficacy in reducing withdrawal and cravings and has a desirable safety profile. Buprenorphine is a partial mu-opioid receptor agonist with high affinity and low intrinsic activity. Buprenorphine's long half-life, high potency, and ceiling effect for both euphoric sensation and adverse effects makes it an optimal treatment. Buprenorphine is shown to be an evidence-based, safe, effective treatment for opioid use disorder. Theoretical framework. Framework for the implementation of the COWS assessment for opioid detoxification in an inpatient setting is represented on the Lippitt's model of change. I've listed those here for you, and we'll discuss how they connect with my project. The first part of the model states the need for change is developed by diagnosing the change. Historically, within this inpatient facility, a standard detox is set at 7 days for all patients, regardless of withdrawal severity, but there's a clear need for the length of withdrawal treatment to be adjusted to patients' need and a tolerance of treatment. Secondly, a change relationship should be established and assessed for the motivation and capacity to change. Inpatient detoxification units operate under the motivation to support their patients in the best way possible, establishing a change relationship and the motivation to change. Change can be wanted, but everyone has to be willing to make that change. Next, we need to clarify the assessment for change and determine resources. Due to the clinical severity of opioid use disorder and its high mortality rate, detoxification protocols are not often changed. There will be no change to the medication administered, but the timing and amount of medication could be altered based on the score of severity for the patient's withdrawal. Goals and intentions for an action plan are established. The goals are to lessen the severity of withdrawal symptoms along with the time required for a full detoxification, utilizing a score-based administration plan as opposed to a standard regimen. The alternate is continuing the current way of detoxification, which is a scheduled dose of medication at certain time intervals without using a score-based administration plan. Transforming the intentions into actual change and maintain the change is the next step. The intention was to implement the COWS scale with an adjusted detoxification regimen for 3 months to gather enough data to support decrease in withdrawal symptoms and shorter detoxification timeframe. Lastly, the change is generalized and stabilized, as well as helping relationship of the change agent is phased out. If the evidence supports that the proposed detoxification regimen is more effective of its goals with the current detox regimen, it should be adopted and maintained in current clinical practice. Intervention. Prior to this quality improvement project, there was no consistent education provided for the nurses or providers regarding administering the COWS assessment. Strategies were implemented at the clinic by the author in collaboration with providers, registered nurses, clinic nurse manager, and other support personnel. The following strategies were implemented. An educational intervention was presented to providers and nurses that included current practice guidelines for administering the COWS assessment form. An education of providers and nurses on how to use this assessment to guide treatment options for symptom management and document the assessment in the EMR was provided. Methodology. Education. First, staff were educated on COWS assessment and how to document it, and providers were instructed on how to utilize the assessment dosing of medication-assisted therapy during detox. Implementation. The project was implemented after a 12-week time frame. Data was collected pre and post. This was a qualitative retrospective chart review, pre and post. The inclusion criteria consisted of 18 and or older, admitted to the crisis stabilization unit, having a diagnosis of opioid use disorder, and all genders were included. The sample size was 123 patients. There were 62 participants pre and 61 participants post implementation. Analysis. To answer the question, does initiating and following the clinical opioid withdrawal scale, also known as COWS, decrease withdrawal symptoms and allow for faster detoxification for inpatients admitted into a substance abuse facility as opposed to a scheduled detoxification protocol? Qualitative data was used to evaluate if using the COWS assessment decreased length of stay as well as withdrawal symptoms. De-identified data was collected and transcribed into a data collection sheet, then imported into an Excel document. Scaled data was used for the measurement and uploaded to the Statistical Package for Social Sciences, or SPSS. Descriptive statistics were utilized to guide the statistical analysis. A Mann-Whitney U test was completed and a sample size of 123 patients were reviewed. The Mann-Whitney U test is a non-parametric test that is used to compare two sample means that come from the same population and used to test whether two sample means are equal or not. Originally, we were going to use a t-test, but the assumptions for that test was not met. Initiating and following the clinical opioid withdrawal scale did not decrease detoxification time as measured by length of stay for inpatients admitted into a substance abuse facility as opposed to scheduled detoxification protocol. Length of stay pre-implementation was 6.8 days and post-implementation was 6.9 days, showing no difference in utilizing the scheduled detoxification versus a more personalized one based on COWS scores. During the project, there were only 3 providers who helped with coverage during weekends and holidays, as well as weekdays. No change in providers occurred during the test period. This is a graph of the initial COWS scores for the patients post-intervention. The orders at the facility states detoxification should not begin unless the score was at least a 7 or above. An unexpected finding included evaluation of initial COWS scores. It was found that 22 out of the 62 post-implementation patients, or 35%, had a COWS score of 7 or below. As you can see, some as low as 3. However, they were started on detoxification, which goes against the standard order that was written. To prevent harm, this needs further evaluation because starting someone on detoxification who is not in true withdrawal could cause them to go into precipitated withdrawal or withdrawal symptoms greater than if they had no detoxification medication at all. This is a graph of the average withdrawal score. Looking at the scale, you can see that no one during this time frame post-implementation of the detoxification process had a score over 9. COWS assessment tool ranks symptoms between 5 through 12 as mild. Based on the chart, 40% of patients utilizing COWS scores had no symptoms or scores under 4, and 60% had mild symptoms scored under 9. This demonstrates that these patients post-implementation were well controlled with their symptoms. What is not known is whether providers adjusted treatment from the standard dose or not during this time frame. The strengths of the project were that all staff were educated on the COWS assessment, need for use, implementation, and the importance of the tool. Limitation. Length of stay did not correlate with lengths of detoxification for a variety of reasons. Initially, this author wanted to create a protocol based on COWS score with dosing the medication, but the facility opted to allow providers to adjust accordingly. This created a flaw in the study. Another big limitation was assuming that the length of stay was the length of detoxification and the patient would be discharged, which turned out to not be the case for multiple reasons. Finally, we only had a 12-week time frame to look at the data to see what the difference it was making. Some other reasons included dual diagnosis requiring treatment, multiple substances abused, placement and discharge planning, not having an adjusted MAT dosage correlated to CAL score, and short study time. Implications for practice. Staff need to be re-educated on what score to implement detoxification. The CALS assessment is a valuable tool and is utilized initially to begin MAT treatment or medication-assisted treatment. Continuing it throughout the withdrawal period and adjusted MAT based on scores has great potential and support from literature. More studies need to be done to find the optimal dosing pattern for opioid withdrawal. Implications for healthcare policy. Initially, the study revealed an issue with the standing order utilizing the CAL score, which will help shape further policy and change current practice. It is also a first step to shaping policy in the future surrounding this tool. In conclusion, the Scholarly Project shed some light on understanding the clinical opioid withdrawal scale and how it can safely and effectively detoxify patients off opioids. Clinical training on its use to measure symptoms of withdrawal was done and implemented successfully. Developing a protocol to use this tool for managing withdrawal symptoms effectively still needs to be done. Buprenorphine is still one of the leading medications for opioid withdrawal and induction into maintenance treatment. Multiple studies have been done on the accurate dosing of buprenorphine when inducting a patient into a medication-assisted treatment or maintenance program. However, very few have been done to show a standard dosing protocol for detoxification using the CAL score over several days. I also have listed my references here for review. I appreciate your time in listening to my scholarly project presentation and hope you have a great day.